Hi everyone, I'm Adrienne Garashi. I'm a program manager and lawyer at the Center for Public Health Law Research, and at some point was sitting in these seats as a law student at Camplain University. So thanks for having me back. Just a note about the format of this panel. We're going to have a rapid fire session that distills complex issues using 4 critical questions. So those questions are, what is the public health issue? Where does the law fit in? What is the evidence supporting reform? And what is the way forward? So Bennett Allen is a PhD candidate in epidemiology at the NYU Grossman School of Medicine, where he's affiliated with the Center for Opioid Epidemiology and Policy. His research focuses on the evaluation of supply-side policy responses to the opioid overdose epidemic. Before joining NYU, he worked for many years in drug policy for the New York City government. Next is Lauren Kuhlik, who's an associate at Tycko and Zavareei LLP, where she practices consumer protection, prison conditions, and whistleblower law. She was previously a fellow at the National Prison Project at the Epidemiology, where she worked to improve conditions of confinement for pregnant and postpartum people. Lauren earned her JD and MPH from Harvard University in 2017. Carolyn Camplain is a senior research coordinator at the Center for Health Equity Research. Carly received her JD in 2015 from Arizona State University and is an interdisciplinary health PhD student with a focus on health equity and MPH programs equity at Northern Arizona University. Her focus is health and healthcare access of Indigenous peoples in jails and prisons. And then we have Cerulli, who has a unique scientifically based career path that seeks to combine legal, public health, and mental health perspectives to enhance the human rights and well-being of people marginalized due to economic, safety, health, and legal concerns. As a professor of psychiatry at URMC and the director of the Laboratory of Interpersonal Violence and Victimization, she's promoted research in diverse criminal justice, community, and health settings, and in 2016, co-founded an innovative medical law program that integrates health, legal, and advocacy services for victims of IPV. Dr. Cerulli also directs the UR Susan B. Anthony Center. And with that, I'll turn it over to our panelists.
Thanks to Professor Well from the Public Health Law Research today. Bennett Allen with the Center for Epidemiology and Policy at NYU School of Medicine. I'll be talking about public health and police partnerships in this sort of interesting and unique format. So just to start, we're all very good. It's been a primary public health crisis for the last 20 years going on, over 500,000 deaths since 1999. I'm going to focus only on one policy response. There's a very broad, multifaceted policy response. I'm going to focus right on public health and police collaborations today. The primary policy response. What is our integration of public health and law enforcement agencies and policy agendas? So really focused on data sharing as a primary element. I'm not going to get too much into that today, but really focused on building up joint policy and programming and often using data as a tool to integrate that and build those programs. It's a policy priority. It's a priority area for both CDC and OTC as well as DOJ. So there's a lot of money into building out these partnerships at the local level. There's a big push to make these happen nationally. There's very little research into actually do these work, do these help, are these good, what are the challenges to this? There's a lot of research around, for example, giving police naloxone. Everyone thinks that's a great thing, but what about integrating these actual at the systems level integration? So there's not very much research there. And we would argue that there are some unique hurdles to really building out effective collaborations. So thinking around the disciplinary objectives of public health and police, thinking around sort of the population lens versus the case lens. And as well as the types of uses of data. So thinking around public health indicators, public health mortality data, public health population data. When law enforcement uses population data, we're really not getting a sense of drug trends or drug harms that are scalable for public health. So when we talk about data sharing, It's generally one directional from public health to law enforcement rather than bi-directional. Thinking around arrest data tell us who's being arrested, not necessarily who's being targeted by police, and not really giving us clear, useful indicators for public health interventions at scale. Where the law fit in, collaboration really has functionally expanded the role of police in overdose response, and this is sort of happening alongside police, more utilizing and understanding overdose mortality data as one of their key indicators. As well as, many indicators that I've talked about are tendency in the United States to lean on police as primary first responders, really regardless of the incident type. We see police sort of arriving first, whether that's a matter of functionality from the jurisdiction from a funding standpoint or a choice in a better funded jurisdiction. So really, this as happening alongside the proliferation and use of drug abuse homicide laws and prosecutions, and I think that's the key takeaway for the legal audience is really thinking around the formal reclassification by police, sort of happening alongside this use of mortality data of transitioning overdose scenes from accidents to crime scenes or accidents to potential homicide scenes. Just to give one example of actual formal protocol changes where this is happening in New York City, now at overdose scenes, homicide detectives are dispatched sort of as a matter of course, as a matter of control procedure. You see some other jurisdictions as well, Buffalo, among others. So this really reinserts criminal legal threat into the overdose response, that we're really hoping that the American laws are designed really to eliminate, to undermine the American laws that work there. We would argue, this is really the psychiatric emergency responses, many, this has been talked about a lot today, might offer a template for public health only or public health primary overdose responses. So the Eugene, Oregon model is many people have been talking about, where the 911 calls are diverted away to dedicated mental health professionals. So this psychiatric model is there a pickup in the implementation of it that I think colleagues have talked about today, but really thinking around, could this model be imported to overdose? So we thought that that's implemented here in Eugene, cost savings, and also more importantly, no risk of arrest for police killing. So if the police aren't there, the person can't be killed by the police. And we have primary public health primary overdose responses. We have ED-based responses, and community-based responses, and these are effective. They're associated with increased retention, care, and treatment. So really, we want to scale these up. We know these work. So as a psychiatric response is expanding nationally, then Denver, we see in other cities, New York City actually just recently announced 2 days ago their expansion citywide. And the Biden administration's Determinants plan included dedicated funding for primary psychiatric responses. So $1 billion committed over the next decade for these to build these out at the local level across the country. So can we harness any of this political momentum for mental health reform to help think through new overdose prevention and responses and new opioid responses? We think the pieces are in place. We know that the ED-based models, we know what they are, we know that they work. The community-based responses, we know what they are, we know that they work. But we just need to fund them, really. So in light of the time constraints on this, there's a lot I left out. Just sharing my co-authors on this work, as well as we had an article from a few days ago that presented some of this in a little more detail in PNAS. So going to plug that, and just also note that this is sort of the really beginning of hopefully a much larger empirical project where we're starting with some qualitative and quantitative work, looking at these public health and police partnerships with a little more rigor. So with that, I'll hand it back to you, Adrian.
Lauren, when you're ready. Okay, sorry, I didn't hear anything that you just said there. So I'm going to go ahead and share my screen. See if I can get this to go as a slideshow. Okay. Hi, Al. So I'm presenting today about how the criminal legal system fails pregnant people who have opioid use disorder. And this is actually an issue that's much broader than this specific population, but because this is such a vulnerable population and the criminal legal system presents such a serious issue for them, this is kind of where I wanted to focus. So speaking about what the public health issue is, I have two charts here that both come from studies by Carolyn. The first one is from pregnancy outcomes in US prisons, 2016 to 2017. And the second one is, it's actually in the slide there, opioid use disorder incidence and treatment. And so just to give you a scope of the issue in terms of the number of pregnant people who are admitted to prisons and jails each year, I think that this is the estimate for 2017. So you can see it's about 5,000 people churning through local jails and about close to 4,000 going through state prisons. Out of those folks, we just have a very high number of them have opioid use disorder. And the second chart demonstrates what kind of medical treatment for opioid use disorder is offered for people who come into prison or jail pregnant. And I think, you know, I wanted to show this because a lot of prisons and jails actually offer treatment for opioid use disorder, but they only offer it during pregnancy. As you can see, 50% of state prisons and 50% of jails, and that's not of those who offer it, of the total jails, will discontinue treatment for opioid use disorder immediately postpartum. This is an especially dangerous time to discontinue treatment. It puts folks at risk of relapse and death, and also just demonstrates to people, you know, we don't care about you, we don't care about your health, all of which also undermines the possibility of treatment. And separation, you know, placing people who are pregnant or postpartum in prison or jail is just a broader public health issue as well. This population, they tend to come from extreme poverty. You know, they're being separated from their kids, which makes their children more likely to be placed into the family regulation system, which is very dangerous. Foster care for children can be very harmful when it, in many cases. And just being placed into prisons and jails presents serious harms because people are separated from their support system, they're separated from their medical care, they're separated from you know, people who can help them, and they're denied their autonomy, their ability to self-advocate, as well as the actual conditions such as shackling during pregnancy and labor, solitary confinement, surveillance, strip searches, all of these things which further undermine medical and mental health, especially for a population that has complex and serious mental health needs. And of course, these systems are all layered on top of existing types of oppression. So for example, if you look at a Black woman who's pregnant and incarcerated, she not only has to deal with all of the racism of the criminal legal system, but also dealing with medical racism. So for example, she has to convince a guard that her medical symptoms are serious enough so that that guard will allow her to see a doctor. When she sees the doctor, she's still going to deal with medical racism, which is a reason that the Black mortality rate, the mortality rate for Black women is so much higher than for white women, as well as other negative pregnancy outcomes. So it really just exacerbates and reinforces those existing systems of oppression. So talking about where the law fits in, I just wanted to give a couple of quick suggestions on how the law can address this issue. Basically, we need fewer people incarcerated. There's not really a great way to say, okay, take the system that fundamentally harms people and separates them from their support structures and takes away their autonomy and make it compatible with public health. So just to give a quick example of, you know, looking at how many people we'd have to decarcerate just to get to where other countries in the world are. Our incarceration rate is just staggering. So a few things that I wanted to put in there first is decreasing admissions to prison and jail on the front end. So one that I wanted to kind of double star is the elimination of cash bail. This would have a disproportionately beneficial impact on women because more women are in jail rather than prison, and women come from who are entering jail and prison come from an even more impoverished background. And so that would really provide an immediate way to reduce the amount of incarceration, particularly of women or other people incarcerated in women's facilities. Also just looking at decreasing criminalization and decreasing reliance on police to address kind of everyday concerns, just to kind of keep people out the front door. Second is decrease the amount of time that people spend in prison and jail. So a couple examples would be decreasing our sentencing, the length of our sentences overall. The US has extremely long sentences, not only for drug use, but also for crimes of violence. And we also need to look at getting rid of mandatory minimums and getting rid of sentencing enhancements that can take a crime that might have a relatively shorter sentence, but then based on other circumstances, such as that person's past history, put them behind bars for a really long time or the rest of their lives. And then third, increasing options for release. So lots of ways to do this. President or governor using clemency powers, creating a presumption of release on parole instead of someone having to prove that they're ready to be released, make the state prove that they should be allowed to continue caging that person, increased risk use of a humanitarian release, and just decreasing supervision of people on probation and parole to prevent a cycle of reincarceration. And so evidence supporting reform. This is just one example looking at, this is from the Sentencing Project, looking at 5 states that were able to decrease their prison populations by, looks like, as much as 25.2%, using many of these decarceration strategies. So these things can work, and I'll also just add, there's a lot of evidence of the harm of incarceration for individuals and for families, such as the harm of having an incarcerated parent can lead to poor health outcomes later in life. Having a mother in particular be incarcerated can force a child into foster care unnecessarily, which is really harmful. If you want to look at a public health example, during the COVID-19 pandemic, there's just been a huge numbers of deaths and preventable illnesses as a result of our system of incarceration. And this has been especially harmful in Black communities. And of course, because people generally don't stay in prisons and jails for life, the vast majority of them return. These things reverberate throughout communities, and they don't just stay inside prisons and jails. And then kind of talking about the way forward on this last slide here. Ultimately, I think a lot of us recognize that we need to move towards a system of serious decarceration or even abolition. Obviously, I'm not talking here about abolition per se, but while folks are kind of working towards that as a broader end goal and thinking about the feasibility of mass decarceration, I gave a couple of very fast examples, and I do think that there's some political will to do this. There were some jurisdictions during COVID that significantly decreased their jail populations. There were a couple of jurisdictions that decreased their population of people who are pregnant and incarcerated. I can say, in one state I looked at, there was probably an 80% decrease in the number of pregnant people in the prison. But those things are not necessarily set. A lot of those numbers are rising again, and they weren't, frankly, very widespread. So I think that we need to kind of recognize the biases that we have in order to make this more feasible. For example, people wanting to talk about nonviolent drug offenders versus everyone else, or people who commit crimes of violence versus people who don't. And we just need to recognize that this is a system that is incredibly racist and oppressive and just, again, re-entrenches a lot of issues, as I discussed earlier. And so we need to make sure that when we're talking about decarceration, we're also talking about these broader systems and not focusing on kind of the most sympathetic set of individuals and ignoring everyone else who's impacted by these systems. Yeah.
in health equity, and also a bar attorney in the state of New Mexico. I'm talking about healthcare and tribal jails, legal implications and potential solutions. I want to start really quick by just introducing what tribal nations are, what indigenous peoples are. There are 574 tribal nations in the United States alone. There are numerous state recognized and so many more who were denied their sovereignty. Okay, I'm sorry. Yeah, thanks. Okay, so I'm just going to give a really quick, bit of background. So tribal jails are correctional facilities operated by tribal authorities or Indian Affairs, formerly BIA, on tribal lands for those who are subject to tribal jurisdiction. In the US, there's about 84 jail facilities with almost 10,000 yearly admissions. I just want to recognize that not all tribal nations have jails, and they sometimes have agreements with county jails and other facilities, similar facilities. In 2010, the Tribal Law and Order Act provided tribal courts new felony sentencing authority, which allows tribal jails to hold individuals for up to 9 years. However, even with this new Law and Order Act, jurisdictions on tribal lands is complicated and varies by each nation. Due to overcrowding, understaffing, antiquated facilities, and a lack of physical capacity to hold individuals longer than a few days, the Federal Department of Justice provided grants that supported planning, constructing, and renovating tribal jails to assist with this increased sentencing power. So these grants didn't offer funding for operating or maintaining these facilities, and the responsibility fell on the tribes. And tribal voices were not really heard when creating these facilities. So these grants failed to provide tribal jails with adequate facilities for healthcare services, which means none. So funds could be allocated, or funds have to be allocated to healthcare services for that. So what's the issue? Why is this important, and what are the challenges? So individuals who are or who have ever been incarcerated have worse health outcomes than those who have not been incarcerated. There are many stories of issues in tribal correctional facilities across the nation with healthcare gone wrong. The example I have is within the first 3 months of the new Tuba City correctional facility being open on Navajo Nation, there was an outbreak of 44 individuals who are incarcerated and staff of tuberculosis. And 44 doesn't sound like a lot, but tribal facilities are much less, much smaller than regular jail facilities, and we are in a rural area. So facilities are understaffed and have no healthcare staff, and then detention officers are often makeshift nurses. So available correctional officers must also transport people from the tribal jail facility to either IHS, Indian Health Service, or Tribal 630 healthcare facilities for treatment, and really as minor things as even medication. So they must maintain a security vigil also, which means that they're deprived of healthcare or of their correctional staff at this jail itself. So there's so many challenges. One is there's a disconnect between tribes, states, and federal governments, which means there's not a lot of programs for indigenous peoples in the United States. And there's a varying level of impact, so some people just don't care. Like I said, there's only 84 facilities across the nation, and there's 574 nations. Finally, there's so many financial constraints. State and local jurisdictions are able to pay for healthcare in correctional facilities by levying property taxes. Tribes do not have the same ability because federal law prohibits them from imposing property taxes on this federal trust land. So this puts a huge burden on tribes themselves. So where does the law fit in? Indigenous peoples and incarcerated populations are two of the only populations with a guaranteed right to healthcare in the United States. However, the federal government does not fund healthcare in tribal jails despite its responsibility to do so. This trust responsibility is a legal principle, and it's undisputed. There's an undisputed existence of general trust relationship between the U.S. and indigenous peoples. And the purpose behind this trust doctrine is and always have been to ensure the survival and welfare of Indigenous peoples and Native nations. In addition, tribal sovereignty can help tribal nations build on their successes. We talked about that at the lunch about building successes through people of color. Tribes know what is needed in their communities, and they are already pretty much succeeding with very shoestring budgets. So what's the evidence? Healthcare access is necessary to end positive public health outcomes, which is absent, completely absent in this case. Another is Medicaid. Medicaid, especially with Medicaid expansion, has provided healthcare access to millions of those who cannot afford it. Healthcare is expensive, and Medicaid covers a high percentage of people who are incarcerated and helps supplement Indian Health Service budget, which Medicaid represents about 13% of the program operations and covers around 27% of non-elderly Indigenous adults. However, by law, Medicaid's inmate exclusion does not finance service people who are incarcerated with extremely limited exceptions. And also, Indian Health Service and Indian Affairs are depleting funds pretty rapidly. I actually removed this slide, but I just want to point out really quick how important that number is. IHS has just over $3,000 per person per year. Federal prisons have $5,100 per year expenditure, and tribal jails have $0. Sorry, I'm so sorry. I'm so sorry, everybody. You can keep there. That's perfect. So what is the way forward? The first step is to strengthen what evidence we have. We need data. I'm a lawyer. I'm also a scientist. And so this is really the first step. If you go to Google Scholar, there's nothing on this topic. The federal government can provide tribal communities with funds to add healthcare personnel and facilities in the jails. However, they will need to prioritize input from the tribes themselves and provide long-term indefinite support for healthcare and staffing. We want to utilize IHS and BIA funds for tribal healthcare services in a different way. We don't want to just spend what they're already getting. As you saw, $3,000 doesn't put you a whole lot per year. We want to add line items, do not just supplement. We need more resolutions and legislation. The National Congress of American Indians has developed a resolution for a request for more funding for IHS and BIA because of the lack of funding from the federal government. And it really does jeopardize the financial stability of healthcare in tribal facilities, 638 and IHS. In addition, Congress should amend Medicaid to exempt tribal correctional facilities from this inmate exclusion due to the fact that the exemption was on the assumption that state and local jurisdictions can levy their own property taxes. And finally, by allocating funds and allowing tribes to run their facilities more appropriately, more positive health and criminal justice outcomes will occur. Thank you.
Thanks so much to all our panelists. I think we have time for a couple questions. Okay, well, if not, something that I'm also a fan of is action items. So maybe each of the panelists could give the audience an action item or two relevant to, whether you're a community member, academic, whatever it is, something that we can personally contribute.
Action would be if everyone could find out in their jurisdiction what the police response protocol for an overdose is. I think that would be useful for everyone to know.
Good action item for everyone is to, if you don't know yet, find out what Indigenous land you stay on. There's websites out there for you to find out which ones you're currently living on, and everyone in the room lives on Indigenous, stolen Indigenous planned. Also, if you want, contact your nearest tribal nation and see if there's any assistance that you can provide. A lot of you are lawyers, statisticians, and let me tell you, they need help.
I would say pay a lot of attention to what's going on with your local elections. This is a really easy way to get involved in decarceration, is just to vote for folks who are going to decarcerate fewer people, judges who are going to do lower sentences, and lawmakers who are going to be passing less intensive and harmful laws around criminal sentencing.
And I think for the talk I gave, I would suggest that people, no matter where they're standing in terms of their professional or personal hat, to consider offering time, talent, and treasure to the issues of intimate partner violence, child abuse, human trafficking prevention, because no matter who you are, we need your ideas and your resources. So thank you for being here.
Does anyone have questions now? Okay, thanks everyone.